Hello, hello. This is Dr. Kelly, and I have a very special guest with me today. This is Mrs. Simone McConney. She is, I should have asked that before I said it. She is a practicing podiatrist in Barbados, and we are going to talk today about diabetes and your feet. I have one person so far. As you come on, please please share the video, please say hello and say where you're joining us from. I'm going to wait just a little bit to see who else is going to join us. And while I wait, I'm going to share the video to my personal Facebook page. Also, please put any questions that you guys have about diabetes and your feet. This is a topic not only for patients, but also for practicing physicians. A lot of us don't even know where to start with when it comes with managing the feet in patients who have diabetes.
And those words you just said are scary.
What do you mean? It's the truth. I treat the blood sugars and stuff. I do a foot exam on all of my patients at all of their visits.
Well, that's very good.
Bad. I say, oh dear, you need to go see your foot doctor. So this is going to be educational for me as well. So we can get started. Miss Simone, what should I call you?
Simone.
Simone.
That's definitely never going to change. I used to be Simone Lord, and that changed.
Okay.
So now
just Simone. Okay, Simone. Tell me more about your practice in Barbados, the kind of patients that you see, about what is a podiatrist? What do you guys do?
Okay, so first of all, we're probably one of the few people that love feet. So We love feet. We love feet to work well. We love the fact that people have 2 feet and 10 toes. And with diabetes, that's something that we want to obviously make sure you always have 2 feet and 10 toes. Mm-hmm. And in Barbados, podiatry is actually quite a new profession, not only for Barbados, but the region. I mean, across the region, we only have about 13 podiatrists.
The whole Caribbean, you mean?
Oh, yeah.
Wow.
So as a result of that, I mean, I've been here for now over 20 years. And, over the years, it's really not something, because some people just do not like feet. And people don't like their own feet. So going into a profession where that's all you're seeing every day, all day, I don't think it's something that's attractive. But it's such a rewarding job. People come in with foot issues and they go back out. So over the years, I've done lots of shows educating on podiatry, on foot care, on footwear, on diabetes. And my specialty and what I love is wound care and diabetic foot, because again, that's something that's very rewarding. You have someone with a hole in their foot and it heals and they go back to regular life with no amputation. And that's where we put up lots of dancing and cheers in our waiting room where we go, yeah, we made it. So over the years, I think that we've done quite a few things. And one of the things that I have been involved with is the Diabetes Foundation. I was a founding member of the Barbados Diabetes Foundation and the Maria Diabetes Center. And I guess I was strategic in making sure that we had a diabetic foot clinic within that multidisciplinary arena, because the only way really of managing the diabetic foot is with a multidisciplinary team. So although podiatrists play a huge role, and many studies will show we're kind of the gatekeepers, because there are things we see that you don't see. So yeah, you may examine the foot, you do the pulses. Do you know about the touch test? So, there's no excuse now. If you don't have a monofilament, you can use the touch test, the Ipswich touch test.
You might have to educate me a little bit about that.
Okay.
So let's start. So basically, I see patients for diabetes every 3 months. So I do the whole physical exam, talk about blood sugars. I feel for their pulses. I use my monofilament. So you're saying if I don't have a monofilament, I can do the touch test. So share more about that.
So the touch test is literally just that. It's a touch.
Okay.
And in the absence of the monofilament, because the studies show that it's just as good at determining loss of sensation. And then what's really good is that there's actually a study right now. The results are not out yet, but there's a study right now, like in Grenada, where they're teaching some of the places, like in the villages and in the hills, how to do the touch test, because the reality is if you cannot feel, you cannot feel. And if you cannot feel, you should not be wearing anything. You should always have your feet covered. And you should always have someone who's examining your feet. The one thing we are always challenged with here is footwear and the fact that it's hot. People like to walk around barefooted. People keep sheep and they have farm life. They go outside barefooted, and accidents happen. So if you're diabetic, you want to know what status you are. So if you're going to go back to your examination, you want to go back to, okay, so you've got this diabetic foot in front of you. What risk category do they sit in? Okay. And how much education do I really need to give them to prevent? Because obviously our number one goal is prevention.
Right.
Of foot problems, for prevention of anything related to them leading to amputation. And amputation is very easy, especially in the region, because again, we have a dearth of podiatrists, number one, and number two, there's not a lot of limb salvage, there's not a lot of protocols, there's not a lot of processes that are in place. So amputations tend to be first on the top of the list.
Yes. So I remember when it was, so I did my medical school in Caribbean. So I did my internship year at the QEH, and I also did a year of SHO in medicine. And I remember so many people on the surgical wards getting amputations and having to take down those dressings, looking at those wounds every day. So I'm not sure. Do you know what the rate is of amputations in Barbados or in the Caribbean?
Not much has changed over these years. I mean, the studies from back when Professor Hennis had done his study, everything there still stands too. Like there was a study back done in 1998 with Waldron and Ramesh, and they had showed they had something like 80% of female beds and 50% of the male beds were diabetic foot. And Dr. Charles Taylor, he was a great advocate for foot care and foot salvaging, etc. And he did a study back in 2012, and that showed 75% of the surgical beds still have a lot of diabetic feet. So if over that timeline, we really haven't had a lot of change. And I have to say that I used to be very vocal, and then I kind of sat back, and kind of reflected on what needs to happen. And as I look across the region and the Caribbean and built partnerships across the islands, we recognize that we all have similar issues. And then we have their governmental policy guidelines and processes. And like, for example, what we're seeing here with COVID-19 across the world, small island states, we suffer these kind of things with smaller things, like, when you have dengue fever, like when the chikungunya was there, a lot of your resources get caught up in doing those things. And then you lose track of those other problems with diabetic foot.
Yeah. So what exactly is it? Like, we throw around the term diabetic foot. What is exactly a diabetic foot?
So I'm really glad you asked me that, because, most of the definitions for diabetic foot will talk about the diseased foot. So we'll talk about poor circulation. It will talk about loss of the insensate foot. And it will talk of poor healing in the foot, etc. And I still feel in the region, the diabetic foot is kind of like a Cinderella foot, where you kind of see it and you go, oh, I'm not sure what to do with this. Because most of the time, people present with a problem.
Right.
With diabetic foot. They might have been diabetic. So, for example, I had a patient with me that came to see me for the first time 2 weeks ago. And she's been diabetic for 15 years. And she's never had a foot examination. But she had a pulse less. Her dorsalis pedis were not, which are the pulse at the top of the foot. And I'm just saying that for those who are lay people here. They were not present. And she, her ashen appearance, dry skin, brittle nails, I had alarm bells. So I sent her to have ancobrachials and segmental pressures done. And when
and that's to look to see if they're getting enough blood supply to the feet, right?
Correct. So that's the one where they put the pressure cuff on your brachial, on your arm, and then it's compared with as you go down the femoral popliteal all the way down tibial, etc. And she came back with severe. So we also look at the PVR and the waveforms as well, because you're looking for that triphasic pulse.
PVR is like you're looking at the pulses, the
correct. Correct.
Okay.
And she was flatlining in the feet, flatlining in the ankles. So you know what's going to happen? Should she not have had that test done, she would have presented. She may have presented with an insult to the foot, and that would have gone straight to amputation because she doesn't have a good blood flow. With no good blood flow, you cannot heal. Right. And I always say to my patients, if you don't have a good blood flow, you can't heal. So your primary thing first is blood flow. And we need to make sure and maintain blood flow, which is exercise. But of course, another thing that we have in the region is when you get to a certain stage in your life, people like to sit back and put their feet up and go, well, I've done my thing now. I'm sitting now all day. I'm not doing anything. I'm going to eat my food. And that does not also work because, you know, at the end of the day, you're not exercising. So exercise is something you should be doing till you're 100. You should be moving.
And honestly, from what I've seen in my clinical practice, and it's all anecdotal, but I think exercise is the fountain of life. The patient
as well. Have you ever seen old-looking? Have you ever seen an old-looking person that exercises heavily? They don't get old.
No, if I meant that. So like, I'm like, oh my God, this is the secret. Everyone that I see who are in their 70s and 80s, still looking lean, still like energetic, they all do some kind of yoga and stretching or some kind of exercise a couple times a week. So like you said, being retired doesn't mean that you put up your feet and don't do anything and just gain weight. You still need to go out and exercise. And the goal is at least 150 minutes per week. That's half an hour, 5 days a week. If you can do 5 days, do longer, but try to get a minimum of 150 minutes per week. And if you can't do that, just start to do something. Go for a 15-minute walk after dinner. Put on some music and dance. Exactly.
Yeah. Come on, we like her soca.
I know. So why are diabetics more prone to getting amputations?
Well, a lot of it is lack of education. So exactly right what we were saying, because like, for example, that patient, I initially said that she didn't realize she was diabetic because she obviously went through a phase of pre-diabetes. And I think that that's a really great prime time to actually to educate people on diabetic foot. So I think that with regards to amputations, people get damage to their feet. They present too late. We have a lot of challenges with management as well. So, you know, not every doctor or clinic manages the diabetic foot the same way. And my reality is amputation is kind of supposed to be the last resort. Mm-hmm. Did you revascularize that foot? Did you give it a chance to heal? Did you, do they have infection that is like bone infection? Because osteomyelitis is one of those things that, sometimes is easily missed in an assaulted foot, especially if the challenge was there for a while. So for example, something as easy as you get cracks in your heels or you get cracks under the toe, that may be going on for a while. So if you're not examining your feet every day, which is what we try to get patients to do, so that you're familiar with what your foot looks like, so that when things go wrong, I for sure know that was not there yesterday. So it's what they say, it's stitch in time saves 9. So you're catching it really early. And then something can be resolved. But most of the time they present with the swollen foot and, sometimes they're febrile, sometimes, they've got, they're throwing up or nauseous because of the infection. So it's all about presentation. It's all about education. And it's also about protocols and building resources and teams within not only Barbados, but I think across the region, because I think the reality is that we probably cannot afford to have all the resources in one island. So we may have to look at it as more of a resource region when we look at the feasibility of getting this achieved.
So how many podiatrists are there in Barbados right now?
We actually have 9. We have the most.
Okay.
We're the smallest, so we've got the most. Like Trinidad only has like 3.
Wow. So if I have diabetes, right? I tell my patients every day to look at their feet. I tell my patients to look at their feet every day. So if I have diabetes and I look at my feet, like what are the signs or symptoms that would prompt me to say I need to go see the doctor?
Just the fact that you're diabetic.
Oh, so even if I don't have any problems.
I kind of went around a circle and I didn't actually answer that question with regards to the diabetic foot. So the diabetic foot is if you are diabetic, you have a diabetic foot.
So that means
Okay.
So that means
So
even
you
if
will
I have
be
more problems, I still need to go see you then.
Yeah, because there's prevention.
Okay.
So from a preventive perspective, we all have a different foot type. If we had a room of say 10 people and we told everyone take your shoes off and look at your feet, no two people are going to have the identical foot. You know, some are going to have long feet, slim feet, wide feet, narrow feet, big toes, long toes, fat toes. You know, the permutations and combinations go, but we're all going to put our feet in the same shoe. So this is where some of the assaults start to happen. You know, you put your foot in the shoe, and there was an interesting statistic that I came across recently, which was something related to the fact that something like only 37% of us wear our shoes the right size. So, you know, you could imagine that if you have so many people around that are not putting on the right shoe, either the width is not right, the length is not right, the depth is not right. So you're diabetic, you're accustomed wearing poor shoes, or you're accustomed having poor habits, like walking around barefooted outside, walking on hot sand. And then you start having pre-diabetes, you didn't know you had pre-diabetes, then you start getting complications of diabetes, and that comes on very gradually. It doesn't wake you up in the night and go, excuse me, tomorrow your foot is going to be numb. Excuse me, tomorrow, you know, you're not going to be able to, you're going to have poor circulation. So it comes on gradually, and then, wham, you're presented with challenges. So my thing is, once you're diabetic, that gives you permission to see a podiatrist for screening so that you know where you are, what risk category you're starting off with. And then you get to learn some key points with managing your feet, managing your challenges. If you've got clawed toes, you get calluses at the bottom of the foot. You know, if you have a high arch, you tend to walk on the outside of your foot, and walking on the outside of your foot tends to cause different challenges with your heels and fissures and that kind of thing. So it's good to have preventative footwear, preventive orthotics, things that we can put in the shoes to prevent challenges. infection of the diabetic foot. They come up with protocols on managing neuropathy, of vascular disease. So there's no reason that you cannot find a process for being able to manage diabetic foot. The International Working Group guidelines, and then there's the IDF as well, the International Diabetes Federation. So there's risk categories for diabetic foot, as in low, high, medium risk. And those are based on whether you have loss of protective sensation or loss of circulation to the foot, whether you've had an amputation or not. Obviously, once you've had an amputation, then you become high risk, and you should. And it also then dictates how often you're seen, like whether you're seen every 6 months, 12 months, or 3 months.
Thank you for talking. My internet just, I don't know, had a power surge or something. I'm like really right in the middle of my Facebook Live. You decided.
I saw you stop, and I was like, ooh, okay.
Thank you for talking. That was great. What did I miss?
Oh, no. I talked about infection in the foot. I talked about vascular disease. And then I talked about guidelines, things that you can use with regards to knowing how often you need to be seen. That's where you kind of just came in. And I talked about the insensate foot, how nail punctures is something that we see quite a lot of here in the region.
Okay.
That obviously a nail puncture means you've put bacteria pretty deep down into the tissues, and really and truly you need to be seen by a surgeon for debridement. And that will be a great way of preventing infection further on down the road.
Okay.
So that's kind of in a nutshell, I think, what I talked about. Yeah.
Okay. So a lot of my patients with diabetes have dry feet. Is that a thing? Like, do diabetics are prone to having drier feet than the normal population?
So when we think of neuropathy, we tend to only think about feeling, but actually you have to think about the autonomic nerve supply and the sensory nerve supply as well. So yes, the autonomic nerve supply is affected, which then affects the dryness. So you get the dryness of the skin, brittle nails, that kind of thing. You also find that you're diabetic that comes into you and has been diabetic maybe for about 20 or 25 years, or poorly controlled diabetes, even not that old. You'll sometimes see them walking with this kind of high, they kind of step a little bit higher as well. And that's all part of the neuropathy process that you would see. They have a high stepping gait. So those are common things that you need to recognize, because this is where footwear becomes an issue. So the dry skin, we always recommend that you use some kind of moisturizer. And I never recommend oils, because I always feel that oils are they just kind of sit there. So unless it's an oil that is specifically devised for moisturizing, you should always have a moisturizing cream. And creams are not equal. And skin is not equal. That's the other thing you need to recognize. I may use a wonderful skin cream, and then I tell you to use it, and it doesn't moisturize for you the same way. So I always say to patients, let's try different ones and find one that works. The idea is that you want to get that suppleness back into the skin. So all diabetics should be moisturizing their skin.
Yes. I prescribe something called ammonium lactate. I'm not sure.
Lots of things out there. So there are also lots of creams actually on the market that are for diabetic feet.
Okay. Did you talk about diabetic shoes or foot care? Did you talk a little bit about that too? Like, is it like a one size fit all, or do you do molding? Like, when someone comes into you, how do you determine if they need to put inserts in or any of that stuff?
So I touched on that a little bit while you were gone, which was just talking about the fact that if a patient comes and we're able to examine, say they have a high arched foot with very prominent metatarsal heads, we may want to put them in a customized shoe. Well, you shouldn't say shoe, customized orthotic, which is a device specifically made for their foot problem. They're the only ones that would be able to wear that. And what that will do is change their alignment and the pressures. And it's the pressures really that cause the problem, because you have to remember the callousing, the shearing forces. So calluses are from shearing forces, and corns are from this type of force. So what you will find is once they're presenting on the foot, it means that they're high pressures. So what the orthotics aim to do is remove those pressures or reduce those pressures. And then, so this is where, remember you started off by saying about diabetic feet need to be seen, period. This is part of the prevention. They may not have poor circulation. They may not have poor vascular supply, poor loss of sensation to their feet, but they need to have some kind of realignment so that they don't get the calluses, because calluses on their own can also cause tissue breakdown.
Wow. Okay. And what about neuropathy treatment? So I found that some of my patients, when their blood sugar levels come down, some of their neuropathy symptoms get better. The numbness and tingling get better. I think if we catch it early enough, it can be reversed. But if someone has been poorly controlled for many, many years, sometimes it's permanent. So what are some of the treatment modalities? Let's talk about medications and then also about supplements.
Well, I don't issue medications, but with regards to things like gabapentin and those kind of things, that's very highly used. But there is also a study that shows exercise improving blood flow to the nerves actually helps improve their neuropathy. So along with also the use of getting your blood sugars under control, and as you just said very rightly, as soon as their blood sugars come under control, a lot of the burning sensations and a lot of those things settle down. And if you can add exercise to that, that also helps to improve the situation. But with regards to their protection, I think we see more problems. People present more, not necessarily with the pain aspect of neuropathy, but they present with the challenges that have come as a result of the neuropathy. So for example, I had a patient just the other day who had a crack under her big toe. She did not know that it was there. It ended up that she ended up seeing a doctor. The doctor sent her to a surgeon. She ended up losing her toe because she did not know that was going on. So I think for a neuropathic patient, once you've identified that patient is neuropathic, you're far better off educating them on examining their feet. And I notice I use the words examining and not looking, because I looked at my hand. I examined my hand. Right. So examining is really important because you want to pick up anything that they did not have there before. And they can get that treated. I've had patients in the past who have been very good. I've had needles removed from their feet. I've had little tacks removed from their feet. Because they are examining their feet, they found these things. They came in early, and we were able to deal with it very early. And by the way, walking in socks is not protective. So if you've got a stem foot and you put socks on and then you walk in socks, you're going to still have a challenge. You want to put something that's protective, as in nothing can get through that to hit your soles of your feet.
So please don't be walking barefoot on the beach. Like some of my diabetics here go walking barefoot on the beach, and they, piece of glass or something gets into their foot, and that's it. They get an infection. So you should always be wearing shoes, especially if you have diabetic neuropathy. Correct?
So yeah, and what I usually recommend for them are the reef shoes, because the reef shoes actually also are very useful. Because at least they actually have a rubber sole that is pretty firm. So it means it also gives them some stability, because one of the challenges I spoke about with neuropathic diabetics is that when they walk on sand that's an uneven surface, they can become off balanced. So the stability comes back when they have a nice rigid or semi-rigid type sole type shoe. And most neuropathics would be the ones that would present with things on their feet that they didn't know that was there, calluses that they've had for years, and then underneath the callus there is an ulcer. And neuropathics usually have a good enough blood supply. So, and we know that there are studies that say if you have one complication, you have them all, but you have them at different degrees. So I have had neuropathics who have had very good blood supply, so they heal. You can almost chop their whole foot apart, put it all back together, and they will heal up perfectly. It's when you present heavily with ischemic disease that you're challenged with really a lot more things, like having to get revascularized and a lot of infection and that kind of thing. Neuropathics tend to get a lot more of like the osteomyelitis because they would have had a challenge going on a lot longer, and then they present a lot later on. So by then the infection has spread to the bone. So I would say from a diabetic foot disease period, prevention is really the key. And a lot of people don't prevent because it's easy. It's so easy. Things like going to shower, wash your feet with soap and water. Boom. Feet, remember, have soles, so you have to wash the soles of your feet too, right? Soaping down between the toes, etc. Drying their feet down between their toes. And then, of course, with regards to coming out, drying between your toes, putting moisturizer on your skin, and examining your feet. How easy is that?
That's pretty easy.
That is just that alone, basics is great. And then footwear wise, making sure that maybe you buy your shoes in the afternoon, because we do get a bit of swelling, gravitational swelling over a day. So your feet may get a little swollen as the day goes on. So buy your shoes mainly in the afternoon, and make sure that especially if you're neuropathic, that you're wearing a shoe with a buckle, strap, lace, back strap. And that's because people with neuropathy walk out of their shoes. So they'll be walking if they're in a slipper, and they'll walk and they'll think the shoe is still on. Because their feet need to be working to keep the shoe on. So what they need to have a shoe with a buckle, straight, strap, lace, Velcro strap, anything that helps support their foot and keep the shoe on the foot, so that as they walk, they only have to focus on walking.
Okay, so prevention is key. So like I said, every patient who has diabetes should be checking their feet every single day. When you go to your doctor, how often should their primary care doctors or even their endocrinologist be checking somebody's feet?
Right. So this is going back to why it's so important to risk stratify them. Because if you risk stratify them and they're not presenting with any loss of sensation in their feet or any vascular issues, you can check that. You can repeat that 1 year later.
Once a year, okay.
Yeah. But if they're presenting with loss of protective sensation and they're presenting with poor circulation in any way, then they should be reviewed at that test should be done at least every 6 to 12 months. But if they have loss of protective sensation and poor circulation, but they've had something else going on as well, like deformity in their feet, etc., then that should be probably every 3 to 6 months. And if they've had an amputation, then that could also be 3 to 6 months, depending on the patient, on their compliance, etc.
Okay. We talked about.
Sorry, I was just going to say that's where risk stratification is very important.
Okay. We talked about prevention. We talked about some medications like gabapentin, which is what I prescribe. I also send my patients to see a neurologist. So you were correct. It is a multidisciplinary team approach. So I send my patients to neurologists. They do the heavy stuff like the Lyrica and the other controlled substances. But I've also heard about podiatrists talking about vitamin Bs and neuropathy. Can you speak a little bit about that?
There's a little bit of research out there that shows that, but I do follow a lot of the international working groups guidelines and guidance documents, and I've not seen that in any of the literature. And I feel that we need to stick with what is just like how here with the COVID. With COVID, we went with what the World Health Organization has dictated and how we have really worked on trying to prevent and get the flat line for the COVID.
Mm-hmm.
We need to do that for diabetes and for the diabetic foot as well. Go along with the guidance documents and protocols and processes that we know have had systematic literature reviews that are working. But there's always those people who talk about the vitamins and so forth, but I've not seen that there's any lasting
effect. Good to know. So let's look at some comments. So Judy is saying hello from Barbados. Hi, Judy. Thank you for watching. This is my cousin, Barbara. Hi, Barbara. Thank you for tuning in. So Patty says, I have type 2 diabetes. I have 4 corns on each feet. I was told to stop cutting them out because of, I guess, the risk of gangrene. It's hard to walk. So what would someone, diabetic or not, like who has corns? Like you said, corns is caused by that, like, pressure you were saying earlier?
I'm really glad she brought that up because there's a corn and there's a corn.
Okay.
So women love to wear those shoes that are kind of pointy-toed and kind of do this. So what happens is, notice what's happening. Your toes are kind of doing that, and this is rubbing like that constantly in the shoe. So it causes hyperpigmentation or depigmentation of the area because obviously you're traumatizing the skin. And if you've done that long enough, it's kind of like going from someone who doesn't lift weights to someone who lifts weights. You get calluses in the palm of your hands.
Mm-hmm.
So they're not really true corns. They're not what we call true corns. They're more like calluses because it's coming from that friction. But because they're on top of the toes, for some reason over the years, people call them calluses.
How do you get rid of those? Asking for a friend. How do you get rid of those?
I'll let you know in a second. Wear better shoes, actually. That's a quick answer. If you actually stop wearing the shoes that stop the rubbing, the callusing and corn formation will go away. Having said that, especially on the fifth toe, because the fifth toe kind of does this kind of thing, that can cause a corn. So you can get a corn, which is going to be a circumscribed area, like a little hole in the butt. Now, if she has this going on, it is, well, first of all, if you're type 2 diabetic, if you're diabetic, period, you should not be putting anything sharp to your feet, full stop. All right. And you need to know you're starting to see how risk stratification comes in so good. Because now if she's type 2 diabetic and she is someone who is a low risk, tell her that, and we know we don't have to keep drilling at home. But if she's someone who's a high risk, we know that we probably have to be calling her, sending her emails to remind her, please don't cut your toes, or maybe get her back in on a regular basis and start counseling. Because the one thing with diabetics is that we need to also be supportive because there's a lot going on in your life. Sometimes they have other comorbidities as well. So definitely do not. And one of the things you can do, first of all, is start wearing better shoes, start moisturizing at home. And if you're not getting anywhere with moisturizing the area and wearing better shoes, then you need to see a podiatrist. If you've got damage to the toes, so some people over the years of wearing the toes, their toes actually start to become fixed in this position, clawed toes. So when they're clawed like that, the corns and so forth on the top, sometimes people have come in and said, oh, I've got all these corns. And when I look at it, like it's just that the skin is thickened because of trauma, but it's not really a true corn and there's nothing to remove. Okay. So it really depends when she says corn, what she really means. And the rest, we talk about gangrene, and I know gangrene is kind of always bantered around, but you know what? Don't be going around in fear. Fear does not really help us. What you need to do is find out what your circulation to your feet is like, and go and get that checked so that you know that you are mitigating your risks with regards to gangrene.
So that raises a good point. Like, should these folks be going to get pedicures?
I always recommend patients who are diabetic to make sure that their pedicurist knows that they're diabetic. And if they're high risk, the answer is no. If they are someone who is diabetic and they're low risk, then yes, that can happen. But once you're high risk, I don't take that chance at all, because if they get cut by mistake, etc., there is an issue. And there's so many of us who normally go and we have someone goes down the cuticle too much or something, and then that causes an infection. So I don't recommend diabetics in general to go, but I get almost beaten up. So I say, okay, let's find out what risk you are. And if you're low risk, okay, we can take that chance, but you need to maintain your routine checks with me every 8 to 12 months. And my routine checks between 6 to 12 months, I will tell you, is really down to how much I trust that patient to be compliant when I am not there, like whipping them into action.
So Dr. Renee said, well, I think that was about your comment that we all have different toes, fat toes, short toes, long toes.
Yeah, we do.
Maureen says, sorry, it keeps dropping. That was me. My internet decided to go off on this thing. Dr. Lord, thank you for connecting me and Simone. Thank you for joining on. Valda is joining as well. Turney is joining. Dr. Levine, he is joining us from Cayman Islands. Turney had a question. How do you pronounce that? I can't even pronounce it.
Metatarsalgia.
Metatarsalgia. What is that? And is it related? Because I don't know what that is. And is it related to diabetes?
Okay, so just because you have diabetes doesn't mean you don't have other foot issues.
Okay.
So it's not necessarily directly related to diabetes, but metatarsalgia is kind of a big blanket term that's used for pain in the ball of the foot. So these are their metatarsal heads. Sorry, this is my hand, but this is my foot. I'm sure I put my foot up here. People will be going, what are you doing? But follow the foot. So the metatarsalgia is usually pain of varying types. So sometimes it's a Morton's neuroma, which is, a pinched nerve kind of between the second and third toe. Sometimes it's capsulitis. There are so many things that could be going on in the metatarsal heads. From squeezing as well. Some people wear too tight shoe, and that causes challenges as well. That actually causes the Morton's neuroma. That's a really nice pinch test to know that the person whether they have a Morton's neuroma or not. So I would say the answer to your question is it's not directly related to diabetes, but people who are diabetic can present with that. But having said that, if they're neuropathic diabetic, they may never present with a foot pain like that. Or they cannot feel anything. But if they're diabetic, obviously with diabetes, you also get you get contractures of the tendons. So what happens as they go on to diabetes, their feet tend to go into contracture like this and becomes pretty rigid. And that rigidity then causes heavy callousing and heavy challenges in this area. And you'll be surprised to know that some neuropathic diabetics will complain of discomfort. But it's almost like a phantom pain. Like they say there's discomfort, but they fail their touch test, they fail their so sometimes we will use a biothesiometer or a neurothesiometer, which is almost like a repeatable test there where you can test the vibration sense to know okay, if we test every single person, they're definitely hitting that they're definitely neuropathic. And there's people that will fail those tests, but they will complain of this weird pain. And it's not really a pain, it's just a discomfort. I hope that helps.
Some other questions here. One I was actually going to bring up, so I'm glad somebody asked about it. So Zarina said that she's watching. Thank you, Zarina. Hi, Clarissa. I'll get to the question. Hi, Jocelyn. Thank you for tuning in. It's very informative. Hi, Joan. You're not too late. This will be up on my page, and Dr. Simone will share it. And so it will always be there. Hi, Camille. Thank you for joining. Dr. Lord is still here. So Clarissa was talking about that she had. I'm sorry?
I'm saying thank you, Dr. Lord.
Yes. So Clarissa is having pain in her left heel, and she saw a podiatrist who prescribed steroids. That brought up an important point. A lot of my patients have this like plantar fasciitis thing, and the treatment that everybody jumps to is steroids. And guess what that does? It bothers me because they call me later and say my blood sugars are in the 300 range, which is, I guess, for our friends in Barbados, divided by 18, like 17, 18 millimoles per liter. So steroids and foot pain, like what is your thought about the whole plantar fasciitis and heel pain thing?
I'm gonna breathe first.
I feel the same way too when I hear I got steroids again.
So I always say to people that steroids is not a quick fix. And the challenge with plantar fasciitis and heel pain is it really depends on why you have it. So why do you have your heel pain and your plantar fasciitis? Is it a foot anomaly, as in, is it the type of foot you've got? Do you have a high arch? Do you have a flat foot? Are you excessively pronating? Are you excessively supinating, as in you're walking on the outside of your foot and then overpronating in order to do toe off? Do you have a plantar flex first ray that's over pulling the plantar fascia? Were you someone who was very slim and then you put a lot of weight on? Were you someone who was very, very fat and you've lost weight? Are you someone who exercises on a regular basis and doesn't change their shoes? Are you someone who needs to change, that you were in a sedentary lifestyle and now you've become more active? So there are lots of things that we need to take into consideration. Then we have to take into consideration the biomechanics of that person. And the nutshell is I do not go the steroid route because it's not a long-term solution. Actually, it's been shown to cause more problems in some people than others. We tend to work towards things like, as I said, why do you trying to figure out? So we are PIs. We kind of try to figure out why do you have this pain? How long have you had this pain? And then we work backwards, and then we look at because obviously it's inflammatory. So once it's inflammatory like that and there's a tendonitis going on, we need the inflammation to settle down. And we use physiotherapists as well. And the pain is back. Yeah, it's racial inflammation in the knee. Right. So we use physiotherapists to get the inflamed area down. So you see, she's saying she was doing a lot of walking. So she's obviously been someone who went from being kind of sedentary to going into walking. So my next question will be, were you doing a lot of walking in poor footwear? Were you using the appropriate footwear for walking? So there she goes. And now she's helping me build her case. So now she's saying, okay, well, she can't wear flat shoes. No, it's not that you can't wear flat shoes unless you have an equinus type foot and you're assessed, etc. But when people tell me you must wear a heel, that means now you have a shortened Achilles tendon. So it means that now when you go foot flat and you're doing a lot more walking, you're overstretching that tendon or overstretching the plantar fascia and making it become inflamed. So now we kind of have to meet each other halfway on on a treatment plan that kind of gets you to where you need to go. And my thing is the steroids do not answer that question. It's more what you're telling me is you have a mechanical issue and a mechanical issue that needs to be addressed.
So therefore, she should go see a podiatrist.
So therefore, she needs to go see a podiatrist.
Okay. Okay. So Harriet Banfield, listening from Barbados, very interested. Thank you for tuning in, Harriet. Let's see what other questions we have. Someone is asking, are heel spurs related to diabetes?
No. So if you're diabetic, remember Ted, if you're diabetic, you can have anything. So diabetes is just a condition, it's a metabolic disorder. Heel spurs is, so if I had a room of 100 people and I grade them on, maybe about 70% of them will have heel spurs.
So heel spur is excess bone?
So it is at the heel and you get this excess bone.
Okay.
But sometimes you get a bursitis around it because it's just like the carpal tunnel thing. You've got tendon attached to bone. So anything that overuses that area results in it becoming inflamed. So heel spurs sometimes is pain. People get pain when it's growing, when it's inflamed. Usually if you have changed, as I said earlier, and heel spurs and plantar fasciitis have their family. They work together. So my thing would be, again, she needs to have that full assessment of PI work done, but it's not directly related to diabetes. But if you're diabetic, you can have heel spurs. If you're not diabetic, you can have heel spurs.
Okay. Okay. Tony, thank you very much. Thank you for tuning in.
It's welcome.
Arundel Lord, they're watching.
Hi.
That's what?
That's my mom.
Oh, hi, Mom. Dr. Lord is saying, and that's for me too, how often should you change your exercise shoes? Because I started to develop what I call them corms. No, I know it's not corms. I guess I had the right shoes on. So I actually went out and changed my sneakers.
You were putting your hand up when you were.
Yeah, I was telling on myself. So now that we're in the pandemic, so I used to go to the gym a lot. I did like kickboxing. I did lots of weights. But now because my gym is closed, I'm doing a lot more walking. So I've actually gone out and gotten like walking shoes instead of cross trainers. But his question is, how often should you change your exercise shoes? And my question to add to that is like, should I have like walking shoes versus cross training shoes, depending on what kind of activity that I do?
Right. So the standard really is that it's down to your mileage with regards to how often you change your shoes. But because people don't track mileage, I tend to give an average of at least once a year. So every 8 to 12 months, you should change your shoes. If you're someone though that, like, I have some patients that run every day, and so I've always found tracking mileage is difficult. So what they do, I just recommend they change it every 6 months. Sneakers are no longer made as equal as before. So what you need to be looking at, if you're walking, but to be honest, in Barbados, I do recommend running shoes for some of the roads here because they're pretty hard. And I do find people find them a little lighter. But ideally, you can go with a walking shoe. running shoe. And if you're, as you said, you've now not been going to the gym, but you've been doing more walking, you need to get yourself a shoe that's related to walking. So a walking shoe or a cross trainer. We don't really do cross trainers anymore. They kind of are very specific. If you go on any of the websites, you'll find that they all have sports specific shoes. And this is because they're looking at the mechanics. So this is all coming back to mechanics again. So what mechanics are you doing when you're walking, running, playing a different sport, whether it be tennis or, basketball, etc. And they have made their footwear and the outer soles to suit this. So this is where the competition in all the market comes. So I would say that you need to not be wearing the same shoe every day, all day, even from a day-to-day basis for work, whether you're diabetic or not. You should have at least 2 or 3 pairs of shoes that you alternate. You maybe wear one Monday, Wednesday, Friday, and the other one Tuesday and Thursday, and then but the following week, if you want to alternate it, you can. Then when it comes to sneakers and training, you should be changing your shoes at least once a year, especially if you're doing, at least 600 to 800 miles. You should be changing it.
So Carissa is saying that she sees a podiatrist, and she has a visit coming up soon, and the pain is not at the bottom of her foot. The pain is at her heel. That might be a heel spur then that she's having.
So if it's at the back of the heel, it could be a retrocalcaneal bursitis as well. So that's the attachment of the Achilles to the heel. That can also cause a spur, which is where the Achilles goes. And that is making more sense because she said that she can only wear a high heel. So
right.
The Achilles tendon is being overpulled there, and that's what's causing that challenge. Okay. So I would look to the fact that she needs to look at coming down slowly. And I would say for her, she needs to think about the fact that she can wear a flatter shoe. She just needs to get down to being flat. And then she needs to think about wearing different heights throughout the course of a week, and not stick to one height.
One height. So Barbara is saying, what type of shoes do you recommend? And must the shoes be purchased from the podiatrist?
What kind of shoes do I recommend for what? I'm
thinking I think she means for diabetics or just for exercise. I'm not sure, but you can address both for diabetics or for just exercise.
Okay, so footwear is really dependent. This is where I was talking about. Remember, we have long toes, short toes, wide toes, right? So you need to know how to fit your shoes. So I think shoe fitting is more important, which is recognizing that if know what size you are, and by the way, the size shoe you are, so it's not necessarily related to the size foot you have. Okay, so your size foot is really to give you the key to start looking for a pair of shoes. So if you're a size 8, you go to the shop and you say, my foot is a size 8, but that does not mean you're going to walk out with a size 8 shoe. And that's a problem that a lot of people don't connect. So you first need to have the length, and you should have a thumb's width over your longest toe. And some people may have a second toe that's the longest toe. And you need to have the width, and you need to know that you can wiggle. I always say to people, you need to have wiggle room. So you need to be able to put your shoes on, lace them up or buckle them up or whatever. Make sure the heel is nicely in the heel counter of the shoe, and then wiggle your toes. And if you can't wiggle every single toe while standing up, then it means that those shoes are too snug for you. I would say not all shoes need to be purchased from podiatrists. In Barbados, I end up selling shoes as a way of trying to be preventative for my patients and actually help them to get shoes, because we have limitations and access to this kind of thing. We can't send them out to a shop to do this. And even so, the shops here who may do them, they don't necessarily do the proper measuring and fitting and so forth. So if you are diabetic, you can source footwear from a podiatrist if you're in Barbados. But otherwise, there are some shoe shops out there that do cater to proper measuring and fitting as well. And if you're buying a sneaker, you should be buying your sneakers with your socks. So you shouldn't be going in a store to buy a pair of sneakers and you didn't carry your socks with you, because you're going to wear them with socks. And you should be wearing your sneakers with socks, because you need to be able, it helps with all the shock absorption, and it helps with also creating some space into the shoe and stops the friction that could possibly occur as a result of wearing the shoes, the sneakers without the socks.
I think that's what the problem that I did was because I go to kickboxing, and we do kickboxing barefoot. So I would wear my sneakers without socks to take them off to go kickboxing, barefoot. And I think that's why I developed the discoloration on my toes. I was like, where did these things come from? I don't like how my toes look anymore. Can it go away?
The secret there is some vitamin E oil.
Thank you. Thank you. Thank you. Thank you.
Give yourself about 3 months, and I'm sure it's going to look much better. But
Okay,
you have to figure the things that caused it in the first place.
Okay.
Barbara, I hope that helped you.
She meant for diabetics. I think you kind of addressed that. And she said she wants to know can designers create more fashionable shoes?
Well, I have to say that I like nice things as well. You see, and I do like nice stuff, right? So I have to say that I actually wear good footwear because I want my patients to realize that you can wear good footwear and look good. So they are more designable, fashionable, diabetic foot shoes, diabetes or comfort or health or therapeutic shoes out there now. And there are lots of brands that are meeting us halfway. So I have to say 20 years ago, it didn't exist. Now it does.
Great. So Clarissa is a very good info. Thank you for watching and putting your questions in. Camille said her video went off. Not sure if you touched on tingling. That's what she has. Not sure if it's nerves or veins, but it's very painful. She can't get her feet to relax, especially at night. And I've heard that from a lot of my patients. Why does neuropathic pain get worse at night? Is it because we're more
She probably has some circulation challenges as well.
Okay.
And I would say that she really needs to have that. She needs to have that touch addressed because we need to figure out why she's having the burning and tingling like that, and it could be more circulation that's causing the challenge.
Okay.
You have to remember, loss of circulation also causes burning and tingling. So you need to recognize that as well.
Okay. So Maureen, she's tuning in from Boston. Thank you for watching. Valda, thanks for sharing. Very informative. Simone, how can they find you in Barbados? Because you just said today that once you have diabetes, you have a diabetic foot. And once you have a diabetic foot, you need to be seen by a podiatrist. So how can they find you in Barbados? People who are on this video, who are going to watch it in the future, and they need to get connected to someone like yourself.
I'm at Comfeet Foot Care Clinic.
I'm sorry. Complete?
Comfeet.
Oh, okay. That's cute.
For your feet.
How can you spell it for us?
COMFEET. Comfeet.
Okay.
So Comfeet Foot Care Clinic. And there are two podiatrists that operate from there. We're both diabetes, love feet.
Where's your practice located?
We're just on Pine Road, Morris House, Pine Road, St. Michael in Belleville. Okay,
and what's your number in case someone wants to call you guys to make an appointment?
436-6030. My caveat will be that right now, because we're in COVID, we have special rules and special processes in place. So appointments are really stretched out because we're only working half days and we have people, a lot of criteria. But yes, even if it's still good to get connected to you, to know that you are a resource for them, because a lot of diabetics do not check their feet every day. They kind of ignore little things. Sometimes we like to be in denial. We don't want to know what's really going on, but you don't want to end up with an amputation. You don't want to end up with, losing your circulation and stuff. So prevention is definitely going to be super important. So please reach out to Simone at I'll never forget that, Comfeet. Comfeet Foot Care. That was right there. Comfeet Foot Care.
Comfeet Foot Care. So thank you, Simone, for coming on. I think this is
thank you for having me.
Informative session. I learned some stuff. I also got my own medical advice about my vitamin E oil, so I'll be buying some of that from the pharmacy later. I'll definitely have you on again. We talked mainly about diabetes, but I'm sure we all have questions about other foot related issues. So thank you for coming on. And thanks for having me, because the one thing that we all have is feet. And the one thing we take for granted are our feet. So we only tend to reach out when there's a problem. So I'm glad that you were able to have me on. So thanks a lot. You're welcome. Bye, guys, and enjoy the rest of your Saturday. Same to you. Bye. Bye.